All right, we're going to get started, everyone. Can people in the back hear us okay? Yeah, and on Zoom, you can hear us okay? Perfect. Okay, well, welcome, everyone. I'm really happy that we've had such a great turnout this morning. We got to figure out how to use my slide advancer. There we go. Okay, so for those of you that don't know me, my name is Ranita Manocha. I'm a physiatrist and a researcher here at the University of Calgary, and I started a connective tissue disorders rehabilitation clinic, which I'll talk a little bit more about. We couldn't have done this event without a ton of volunteers, so I really appreciate everyone who's helped to organize this, and we'll thank them all at the end. But before we get there, I do want to acknowledge that where we are today and a lot of the research that we're going to be sharing with you today has taken place on the traditional territories of the peoples of Treaty 7, which includes the Blackfoot Confederacy, comprised of the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations. The City of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6, so we want to pay tribute to that. So before we actually get into the meat of today, I just have a few housekeeping items. For those of you who are in person, if you don't mind silencing all of your devices. In the event of a fire, our closest exits will be through there to the right and then out the glass doors. The bathrooms are out these doors and to the left, male and female. And we just want you to be as comfortable as you can, so please let our volunteers know if there's anything we can do to make things easier to access for you. Everyone's very friendly. There will be refreshments outside throughout the day, so please help yourselves. We also have some research studies happening today. You're welcome to participate whether or not you're a patient. There's a lab that's looking at how facial shape can predict certain things, and so you'll see all of their equipment here on the right side when you leave the room. And on the left side, there's a number of researchers that are actively recruiting patients as well as control participants for relevant studies. For those of you who are online, we'll be sending links to those research studies if you're interested in participating. There might also be some media around today, so if you don't want to be captured by any media or photographs, if you can please let the volunteers at the registration desk know, and we'll make sure that you're not included. Our event is entirely volunteer run, so I just ask that you be respectful of that. People have just really given a lot of their time to make this happen. There's a lot of students here. Not everyone's an expert on everything, so please just be gentle and respectful. For those of you who are online, we do have people moderating the chat. If there's any technical issues, please just let them know in the chat box. And we also invite you to participate actively during our question and answer periods. Again, there'll be someone moderating the chat box and they'll deliver those questions to us. I also want to acknowledge that it can be really frustrating to live with a chronic health condition that's poorly understood. I just ask that you be respectful of our speakers. We're all trying our best. We're all here to help. We're not experts on everything, and we're here to learn about your lived experience. But please just be mindful. We won't tolerate any sort of negative or abusive behavior towards our speakers. Lastly, this day is really for our patients. We want you to be really engaged, but we have lots of family members, clinicians, researchers here as well. So we ask that you all really engage and participate in our question and answer sessions. And our speakers are all here to chat with you. So during the breaks, please come up to us. Please ask your questions. Please engage us in discussions. You'll see today that actually 2 of the research projects that are being presented were generated from patients' ideas last year. So I think this is a great way to really, engage knowledge in multiple directions. Unfortunately, we're not able to answer any personal medical questions. I hope you can all understand why that would be. So when you're asking your questions, please try to just make them more general. For those of you who are so inclined, we have a social media hashtag. You can also follow our research lab. It's the Better Mobility Lab on X and Instagram. So feel free, even those online, to share any of your favorite ideas or photos from the event. And based on feedback from last year, we were able to get funding to hire a company to record the presentations for YouTube. And so those should be up by the end of the week. Feel free to share them with others, watch them again. And I know not everyone's able to stay for the whole event. There will be some surveys that will be given at the end and will also be sent by email. It's really, really important for you to fill out those surveys because it helps us make this event better in the future. It's going to help generate ideas for future events. And it also helps us engage with agencies to get funding and support for events like this and building up the clinic. So I just wanted to share a little bit about our history. Whoop. So this was our event last year. You can see we had a researcher presenting, we had patients asking questions, we had some interactions with patients and caregivers and family members. Last year was the first time we ran this event. It was a much smaller event, as you'll see shortly. And our goal is really to connect people living with hypermobility, living in Southern Alberta. So I know as a physician, a lot of my patients will say, like, I've never really met anyone, or it feels really lonely, or I feel really invalidated or dismissed. And so I think it's really important for us to see that we're not alone. We are a community, and we can build something better for all of us. And also to really help researchers understand what patients want to know and help patients understand that there is hope. We are trying to do research in these areas. It was also helpful to get clinicians to come to the event last year. There's a lot of clinicians out there who don't know a lot but want to learn more. And so, it is a patient-centered event, but it is really open to anyone. So last year we had only 38 people and 54 people online attend. We actually thought that was amazing. That was huge numbers, but you'll see we have many more people who registered today. About 60% last year identified as patients and 15% identified as family members or caregivers, and we sort of had a smattering of other clinicians and researchers as well as trainees. But this year, super exciting. We actually had 102 people register to attend in person. And when I was helping with the registration desk this morning, there was even more people who came, so that's great. We've had 117 people registered to attend virtually, and I think we have about 45 so far this morning. Most people who registered are patients, but you can see we have a lot of family members and clinicians and researchers as well, which I think is just awesome. So really, the goals of this event are to keep building that community between patients, but also between people who can be allies with our patients, clinicians, and researchers. We want to share information about what's going on in hypermobility research and clinically. And exciting news this year, we were able to get more funding, and so we were actually able to fly in 2 keynote speakers from outside Calgary. We want to really help to drive future clinical and research projects related to hypermobility in Southern Alberta. So this is an idea of what the day is going to look like. Excuse me. We've tried to build in some wiggle breaks. But at any time for the people in the room, if you feel like you need to move around, feel free to go ahead. We just ask that you try to stand by the walls so that you're not impeding anyone's view. There's lots of times for question and answer period, and then we'd like to take a group photo, and we ask that you stay till the end for us to do that. I think it's a nice way to build community and also to show people that, this is an important group. And when I say people, I mean people like in positions of power, policymaker, healthcare authorities, that sort of thing. And we couldn't have run this event without some amazing sponsors. So our biggest sponsor this year is the Connective Foundation. We're really grateful for them. That's allowed us, like I said, to fly in 2 keynote speakers. The McKeag Institute has also provided a lot of support, and the deputy director of the Institute's here, Dr. Krawitz, so we really appreciate their support. The Alberta SPORE Support Unit, which is patient-oriented research, the Faculty of Kinesiology at the University of Calgary, and the Department of Clinical Neurosciences. So please, if you know anyone in any of these organizations, please make an effort to thank them. So I know that we have a wide range of people in the audience. I just want to give a bit of a background as to what some of the terms we're going to use today, and also just a bit of a background about the clinic that I started. So we know that hypermobility is a spectrum. There's lots of people out there who are very flexible or hypermobile and don't have any issues. And then there's people at the other end of the spectrum who are flexible and have a whole lot of other issues, including chronic pain, fatigue, problems with blood pressure. We'll go into all of that. Some of the terms that we'll be using, so you can see here on the left, I'm not going to use the laser, it's making me dizzy. There's asymptomatic joint hypermobility. So those are people who are flexible but don't really have other problems, going through to generalized joint hypermobility, all the way to people with hypermobile Ehlers Danlos syndrome. And wherever you lie on that spectrum between generalized joint hypermobility and hypermobile Ehlers-Danlos syndrome, there's such a wide range of how you could be affected in terms of your ability to accidentally sprain or strain joints, tendons, ligaments, in terms of those blood pressure issues, bladder issues, things like asthma, skin reactions. And so we just need to remember that not everyone's going to be having the same experience. There's wide range, wide severity of how you might be affected in all of those things. And we just have to be really open to understanding that. So these are some of the things that I talked about. So it's not just about having bendy joints. It really can affect all parts of people's body and thus their function and quality of life. We're still trying to understand how many people are affected by these conditions. So I'll group them as hypermobility spectrum disorders and hypermobile Ehlers-Danlos syndrome. Somewhere around 1 in 600 people. It tends to affect females about 4 times as commonly as men. But we're still learning a lot. And we know that in the last decade, this diagnosis has been increasing, and it's something we're trying to understand. Is the actual prevalence of this increasing, or are people recognizing it more? In terms of the Connective Tissue Disorders Rehab Clinic, so I moved to Calgary about 6 years ago, and this was something I really wanted to start based on what I had seen when I was training in London, Ontario. I'd worked with a physiatrist and a geneticist who were interested in connective tissue disorders, and I think it's an area that was really lacking in terms of clinical care. So my goal was to start this as a program to really help people in Southern Alberta, although we ended up taking patients from Northwest Territories, BC, Saskatchewan as well. My focus, given my training, was really on the musculoskeletal rehabilitation, and I'll explain kind of what I am, what a physiatrist is shortly. But really to focus on things like the exercise counseling, bracing, workplace accommodations, joint protection strategies, and the occupational and physical therapy interventions. We've had a lot of issues trying to track data for this clinic. Partly, some of you might know, we switched to a different electronic medical record system in Alberta, and that's caused some issues. We've had 7 administrative assistants over the last 6 years, so it's been a bit challenging to pull statistics, but we're working on a grant to have someone dedicated to actually get some of these statistics. Between 2020 and 2024, we know that we saw 109 new patients, but we also know that that was an underestimate. You can see that most of the patients had hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorders, but we've been seeing people with other conditions like Lewy-Dietz syndrome or Marfan syndrome. And unfortunately, the wait list, currently there's about 205 patients waiting to be seen. So in January, we had to close our clinic to new referrals. We had been trying to make an interdisciplinary clinic. And then when it was announced that Alberta Health Services was going to be split up, those discussions unfortunately got put on the back burner, but that's still the hope. We know that from the patients that we were able to track, on average, they're around 33, predominantly female sex as well as female gender. But currently, unfortunately, it's still just me. But my vision is still, like it was last year, to make this comprehensive center of excellence for clinical care, education, and research for people living with different connective tissue disorders. And I think we as a group can really help make that happen. We just need to keep getting our voice out there. So I just want to touch on what a physiatrist is, because a lot of people have never heard of this term before they've come to see me. So we are medical doctors. In Canada, we would do 3 or 4 years of medical school and then a 5-year subspecialization. Our main goal is to use our medical knowledge to help people function independently and have a good quality of life through things like bracing, injections, physical therapy, occupational therapy, all sorts of things. But we can treat a lot of different things, including conditions affecting the brain and spinal cord, the nerves, the muscles, the joints, the ligaments, and the tendons. So just to give you an idea of the breadth of physiatry, these are some of the patients you would see in general: people after an amputation, a joint replacement. People might work more in sports medicine or do interventional procedures like injections around the neck, the back. Some of us would focus on seeing patients with strokes, traumatic brain injuries, multiple sclerosis. But we can really rehabilitate anything. We have a pediatric physiatrist here. We can do cardiac rehab, respiratory rehab, people focusing on burns. We have some burns experts here in Calgary, cancer rehab. So it makes our field very broad, but also very specialized and hard to explain to people. So why do I think a physiatrist can be helpful in a space like this? I mean, I think we are used to working in teams and our focus is on quality of life. And we know that hypermobility is a very complex chronic condition that does require a lot of different team members probably to manage it. As you can see here, affects lots of different things. So some studies have shown that this is the standard of care for hypermobility. It's just how do we actually build this? And so I think this is really where you come in. It's actually very timely. Next week is Global Patient and Family-Centered Care Week. So I'd encourage you to look at your local hospitals and make your voice known, make it clear that this is an area that we really need help with, advocating for care for these patients. In my experience, often patients are the ones who can make things happen. So please reach out to media, reach out to your local politicians, reach out to health authorities, health foundations, and really share your voice as to why you think it'd be important to have this kind of care. So on that note, one of the guest speakers we've invited today is Dr. Mittal. Dr. Mittal actually works at the only interdisciplinary care facility in Canada for patients with EDS. It's the Good Hope EDS Clinic in Toronto. Dr. Mittal is an assistant professor in the Division of Physiatry at the University of Toronto, as well as holding cross appointments in the Department of Anesthesiology and Pain Medicine, as well as kinesiology and physical education. He holds a master's in health research methodology and has a lot of experience working with people with acute and chronic pain, including conditions like EDS and sickle cell. He's published over 50 articles, and he's very passionate about developing models of care for people with hypermobility and advancing image-guided procedures for pain. So without further ado, Dr. Mittal.
Here? Perfect. Hi, everyone. Everybody's doing okay in the back? Can hear me? Fantastic. Hello, everyone. My name is Nimish. And first of all, I want to thank all of you for making time to come and join us for this Hope for Hypermobility event. Let me see if the slides are working perfectly. Yeah. So my name is Nimish, and I, as Dr. Ranita was mentioning, I work at the University of Toronto, Toronto General Hospital. We actually have it was quite interesting to see how she's trying to build a program, and you know, we are fortunate that we are at a place that we already have a program, which is kind of Canada's, I think, first and only comprehensive assessment program for assessment, diagnosis, and providing interdisciplinary care to people living with Ehlers-Danlos syndrome. This is called the Good Hope EDS Clinic, which we have in Toronto. What we have is a bunch of multidisciplinary providers, which include people like myself who have background in physical medicine and rehab. We have subspecialty medical services that include cardiology, gastroenterology, respirology, allergy/immunology, genetics. We are trying to recruit an endocrinologist and a gynecologist, but yeah, that's work in the process. On top of that, we also have a bunch of allied healthcare providers, such as nurse practitioners and physician assistants, who help us see and assess the patients. We have a team. The way our program is built, we have interdisciplinary self-management program streams which focus more on functional rehab and psychological coping strategies. So we have a team which consists of 2 physiotherapists, 2 kinesiologists, 1 exercise physiologist. They focus on our exercise program, which is called the GEAR, the Good Hope Exercise and Rehab Program. We have a psychology team, which has 3 full-time psychologists who engage in some different strategies, the cognitive behavioral therapies, the acceptance and commitment therapies, and dialectical behavioral therapies, different kind of modalities to help patients cope with this chronic illness, because chronic illness leads to a lot of different problems in their life and daily challenges that it brings. So all in all, that is what we have in Toronto, and we're trying to constantly build our program. So if you look historically, EDS has the medical descriptors that have been used for Ehlers-Danlos syndrome have focused more on joint hypermobility or joint flexibility, People will talk about skin flexibility and skin fragility, and these kind of easily diagnosable without any severe diagnostic tool kind of manifestations have become synonymous with Ehlers-Danlos syndrome. However, Ehlers-Danlos syndromes are not just only about joint hypermobility and skin elasticity. There's a multitude or a variety of symptoms which affect multiple systems in a person who has Ehlers-Danlos syndrome. And there's actually this image which kind of covers the some part of the length and breadth of symptoms that a person living with Ehlers-Danlos syndrome experience. If you'd see here, like, can I get the pointer? Thank you. Yeah, like this. Oh yeah, I don't think I could manage it. I'll try. Gentle movements. Okay, so the center of it is, of course, the hypermobile joints. And we've all known that EDS patients have hypermobility and hypermobile joints, which is well-recognized musculoskeletal manifestation. However, in the last 15, 20 years, as we have come to recognize more and more about this disorder, there's a lot of research which has helped us identify a bunch of less previously recognized multisystemic issues, which can go for, like, if you look at the left side, we start with fatigue. Like, fatigue is so much common in individuals with Ehlers-Danlos syndrome. There's multifactorial reasons. It's because of chronic pain. It can be because of sleep deprivation and sleep disorder. There's autonomic dysfunction or postural orthostatic tachycardia, which also plays a role in that. People constantly complain of, people have ton of gastrointestinal comorbid symptoms. They would have inflammatory bowel syndrome. They would have gastric motility issues or dysmotility, problems with gastric emptying. Mast cell is another association. They would have allergies, bunch of itching, hives, rashes. Some people also have anaphylactic reactions. Other things on the right side of the scoop is one of the well-recognized and I think plays a lot of role is blood pressure, labile blood pressure that they would have, and they would have partial orthostatic tachycardia or orthostatic intolerance-related features, which I'll come to in a bit why they have that. And along with that, when you have a chronic illness which does not fit the usual medical framework of acute medicine, and with a lack of knowledgeable providers, what you have is a kind of chronic invisible illness. And that leads to a lot of, unfortunately, invalidation and stress in life. And that is what ends up, a person who's trying to live along their life, that ends up being anxious. They're invalidated in the scenarios they live in, leads to a bunch of mental health challenges. Each patient have their own journey. Even in the whole spectrum of Ehlers-Danlos syndrome, there's people, even within the same subtype, people who have different severity of disease. Some people have milder variants. They're able to live their life normally, whereas some of the folks have severe comorbidities and they would have a lot of challenges to live. The other thing, which is a common myth I've seen a lot of providers talk about and patients complain about it, is often healthcare tries to relate or link the severity of symptoms with the severity of joint hypermobility. So if you don't have like a Baden score of 7 or 8, you could probably not have that amount of significant problems you're talking about with gastrointestinal stuff or cardiac stuff, which is not accurate. Each patient is on their own journey in this whole gamut of discovering this disease. Patients are like constantly juggling a bunch of medical challenges, and they're trying to just find a delicate balance in managing their life, managing their daily symptoms, having a good quality of life, and having emotional well-being. So what I'm going to do in the next 15, 20 minutes, I'm going to give you a kind of like a bird's eye view of why chronic pain happens and why some of the other manifestations like fatigue or dizziness or tachycardia palpitations, what are the possible or potential pathophysiological considerations that come into play. And then we'll go into a broad, like kind of wide strokes about managing these conditions, some of the things that you can take back home today in terms of how you manage these conditions. The first important thing is pain. Like often people with EDS would have chronic widespread pains, which does not make sense because they have joint hypermobility. They should only have like joint pain, but that is not how it works. If you look at this image on the left side, I'm going to start here slowly with the left side. When a child who's born with hypermobility, in the first decade of life, they're not aware of their joint hypermobility. But what they have is they're going about doing their daily work. Children like to play, But because of that hypermobility, they end up getting multiple micro-instability traumas and macro-instability traumas causing soft tissue injuries. The pains would be localized at that time. We call them nociceptive pains. But as they move on to the second decade, the injuries become more and more prevalent and recurrent. And what that does is that it results in kind of a sensitization in a way that there's neuronal hyperexcitability of pain receptors, the efferent pain receptors, which take the sensations of pain to our brain. And there's alteration of those pathways, which then results in causing them some widespread musculoskeletal pain. Around the second decade, a lot of patients, specifically women, when they hit puberty, there's some kind of hormonal changes or a bombardment of hormonal influences that end up starting a cascade of dysautonomia as well. And with that dysautonomia comes extraintestinal pains. They would have gastrointestinal pains, they would have pelvic floor problems, they would have bladder-related issues, and so on. And eventually, this leads to neuropathic pains, which are widespread. And because the chronic cascade where they're getting injured and their central nervous system is being stimulated, it leads to peripheral and central sensitization. What it is truly means is that they have, it's kind of like a short circuit in our central nervous system in the pain pathways, that even when those influences which are causing that stimulus to the pain system are gone, the pain system is still working. It's kind of like an alarm system which has gone wrong, and that results in widespread pains called the nociplastic pains. And if you complement on top of that POTS and orthostatic intolerance, then they could have fatigue, which comes with orthostatic intolerance. They have often people with EDS have low blood volume that plays into their orthostatic symptoms, causes fatigue. And then I'll talk in the next slide about what goes on as well. And they would have cardiac problems, they would have gastrointestinal visceral problems, and kind of like so on. Now, this picture actually is from a different pathophysiology slide. What this explains is how people develop multisystemic manifestations after viral illness, such as COVID-19. However, we can extrapolate the same hypotheses to Ehlers-Danlos syndrome as well. And there's a subset of researchers who believe that people who have Ehlers-Danlos syndrome have genetic predisposition and vulnerability to pan-dysautonomia. Their immunological system is a little bit altered, because of which they have this kind of predisposition. And when their immunological system is bombarded by a stressor, and that stressor could be, pregnancy, it could be a trauma, it could be surgery, it could be chronic anxiety and other features. It could be also related to puberty. That results in a constant bombardment of that. Results in a constant bombardment of that immunological stressors. And what happens in these genetically predisposed individuals is that it results in the activation of the pain system, because of which they end up developing neuropathic and nociplastic pains. And there's also this persistent inflammation, or due to these immunological bombardments, then results in impaired activity of mitochondria, oxidative stress. That results in all these kind of cognitive features, fatigue, and autonomic dysfunction as well. Now, moving on to this, EDS is a lifelong condition, and there's no cure for this disease. The other important thing is, as I was mentioning before, each patient is different, and there's not kind of like a cookie-cutter approach which we could use in EDS. There's one size does not fit all. But what we can do is, if individuals take a proactive approach to symptom management, they can take charge or control of their life, and they can identify and implement strategies which are unique to them so that they have a better quality of life. Physical therapy is one of the critical elements of this whole multidisciplinary gamut of self-management that we do in Ehlers-Danlos syndrome. Now, EDS research has a bunch of physical therapy interventions that have been talked about. However, there's a lot of heterogeneity in how people describe the interventions. Some of the researchers describe very individualistic approaches, whereas other researchers have focused on broad strokes-based physical therapy. I don't want to bore you with all of that, but this was a scoping review published in 2023, and they looked at a bunch of data. And what they identified was that here, if you will see here, this is the green is the level 1 evidence, which is high quality randomized controlled trials. And level 2 is low-quality randomized control trials and case-control cohort studies. And there's case series and other data. The interventions that they studies is therapeutic exercise that they could find in the literature are therapeutic exercises, motor function training, patient instructions like just patient education and let them do their own stuff, assistive technology, manual therapy, and functional training. What they identified was that there was only meaningful data that they could identify, which speaks to the fact that therapeutic exercises and motor functional training were the interventions that made most clinical and statistically meaningful significant difference in terms of pain, function, kinesiophobia, endurance, strength, and so on. So now moving from it here, okay, one more diagram. I want to show you why exercise is important and what different kind of exercises and why they're important in Ehlers-Danlos syndrome is this image which talks about postural orthostatic tachycardia. Now, people with Ehlers-Danlos syndrome, if you remember the slide from chronic pain, and because of hypermobility, they have these injuries. Because of these injuries, then they want to engage in joint preservation that leads to reduced activity. And then because of this chronic pain and reduced activity, their heart becomes smaller and there's cardiovascular deconditioning, which results in cardiac atrophy. People with EDS also have, there's multiple studies which have shown there's reduced plasma and blood volume that leads to reduced circulating fluid volume in their body. On top of that, because of the lax circulatory system and the venous, the architecture of the veins that we have, they're lax and they're not able to pump the blood back to the heart, there's venous pooling, which predominantly takes place in when we are sitting or standing against the gravity. All of this results in a reduced blood volume that causes a lot of fatigue, dizziness, cardiovascular symptoms, also some cerebral symptoms. There's also another term called the central heart, or kind of like in simple terms, if we would say it's kind of like the heart-brain axis. When we are standing, heart has to pump more for the blood to reach to the brain so that the brain is adequately perfused. If that adequate perfusion does not happen, you'll end up getting neurological symptoms related to some kind of, all these symptoms related to brain fatigue, cognitive features, memory, and so on. So that is why exercise training and reconditioning is quite important in EDS. Now, there's two different kind of exercise principles which we'll broadly talk about. One is related to aerobic conditioning, which goes to the fact for the slide that I just showed you. There's a lot of published literature in cardiac dysautonomia that speaks to the fact that if you would exercise for 30 minutes a day, around 5 days a week, that leads to some modulation of the neurovascular tone and the cardiac vascular mechanisms that blunt the effect of autonomic dysfunction. So that is the goal that a person should move towards, is exercising 30 minutes, 5 days a week. Now, people are at a different place in their journey, and so not everybody can start there. A good start point is you start with 5 minutes a day, and then you increase a minute or two every week in terms of your exercises. If you fatigue, like we have a lot of patients who would say, oh, I would fatigue quite early. If you fatigue early, then you can modify the intensity of the exercise that you're doing, but try to keep that duration consistent. Now, one other literature which is present is that you should try to not miss exercise for more than 2 days on a straight go. There's a lot of literature which speaks to the fact that in healthy individuals, if you don't exercise for 2 weeks stat, your muscle mass reduces by up to 30%. And it takes around 3 times the time for which you were not active to kind of get back to that muscle mass. So those are some things. Now, some people also talk about timing of exercise. If you have problems with insomnia and others don't exercise in the evening, the best times usually are later afternoon and early evening for exercising. When you start exercising, a lot of people with Ehlers-Danlos syndrome have orthostatic intolerance. So you should start on a horizontal exercise activity. So you could start either on a rowing machine, or you could start on a stationary recumbent bike. Now, on the rowing machine, if you have a bigger flywheel, that is better because then it helps you engage larger muscle groups, and rhythmic contraction of those larger muscle groups makes better change as compared to other activities. Once you go from here, I want to show you not those are later ones, but other thing is some people who are better off at a better place in their journey, they can also start with swimming, because swimming is also horizontal exercise, and that is very good for doing some cardiac activity. After 2 to 3 months, you can gradually progress. You can start doing walking, like not only recombinant activities, but standing activities. You could use an elliptical trainer, go walk, jog, use a treadmill, the kind of gradual progression you can engage in. The second type of exercises are graduated strengthening protocols. Now, you have to mix some resistive strengthening along with the aerobic exercises. There's 2 different reasons for that, but one of the most important reasons is to mitigate the risk of joint instability and laxity-related injuries. If you would look at the architecture of our joints, we've got bones, we've got ligaments, and then we've got muscles and tendons. We cannot change the shape of our bones. We cannot change the tension in our ligaments. The only modifiable factor that we have is we can change the volume of our muscles, and we can change the resting tone of our muscles. And that change only happens when you do some gradual resistive strengthening exercises. So that mitigates the risk of joint injury. Now, one important feature that I tell patients is that you should exercise only in the mid-functional ranges. Let's say if you have problems with your elbow, you should not try and go into the end ranges of extension when you're doing any exercises. You should do the mid-functional range, avoid the end ranges of extension for those exercises that you're doing. The other thing is you should not start directly with some free weights. You should start just with sitting posture exercises, and then it could include some Pilates, some kind of like regular Pilates activities, abdominal crunch, sit-ups, and so on. And then you can gradually progress to free weights. Ideally, when you go to progress to free weights, you should take help from some supervision from a trainer or somebody before you start feeling confident in that. Well, there's a bunch of literature as well which is published on it. This is a study I want to show you published by a group from Denmark and UK. In 2023, they looked at the effectiveness of high load versus low load strengthening exercises in hypermobile shoulders. So what they essentially did was that they had patients divided in 2 different groups. Here you can see so they randomized 100 patients, and out of these, 50 patients went into a heavy exercise group. What this heavy exercise group did was that with a physiotherapist, they exercised 2 days a week with a graduated progression of shoulder strengthening exercises. And patients were encouraged to do a 3rd day on their own. On the other side, the right-hand group, they would just give them the routine protocol, which in Denmark they say is providing education and instructions on some range of motion and some mobilization exercises. And then they followed the patient up to a year. However, I think the results which they did, these results are from 3 months analysis, and the comparator score was the Western Ontario Shoulder Instability Index, which they used, and their conclusion was there was a significant difference in their, at 16 weeks, there was a significant difference in their VOCI scores of the Western Ontario Shoulder Instability Index. In the people who were part of the heavyweight group, they felt really better. They complained less subluxations. They felt better quality of life as compared to the people who were in the low intensity group. The second is what kind of braces and supports. There's different kind of braces and supports which are available. Ideally, a person should not be using them all the time, but there are certain times when you have flare-ups and you need to prevent those instability or hypermobility related subluxation events. And there's all different kind of braces that are available. I'm going to touch on a few. But broadly, we can describe braces into static braces or functional braces. These are the small little braces which we use for our small joints, interphalangeal joints, and the thumb, the CMC joints brace. There's a swan neck splint. There's ring splints which are available. Other than that, you can also have lower extremity static bracing, knee brace to avoid patellar subluxation. But where it gets interesting really is functional bracing. Functional bracing includes braces like a give more sling. So this sling is actually, initially it was popularized for stroke patients who develop some shoulder subluxation. It is less cumbersome and it provides you more functionality to do your daily tasks as compared to the static shoulder immobilization splints that you could use. Another good splint is a body braid. Now, body braid, if you would look on this image, like all of these people have different arrangements of these wide bands going all around their body. None of them is similar. Like body braid has a mesh framework or different elastic bands. It works on a principle of providing some kinesthetic feedback and proprioceptive feedback to the body, so it avoids all the excessive hypermobility related events. It also provides some basic compression, although I don't think there's no proven study on if it actually provides the compression and work like a compression stocking. But there's compression stockings that are available. Now, usually people would be prescribed compression stockings, which are kind of like pantyhose stockings, which go up to their umbilicus. And when I started the practice, I used to do that too. And the patients help you learn a lot of things. And a lot of patients, majority of patients would not be able to use it because it's cumbersome. It's so tight, and it was just not convenient for them to use it on a day-to-day basis. And then we looked into it, and what we identified is NASA uses a similar kind of stuff, which is another topic that NASA uses it because there's astronauts going to a gravity-free environment leads to symptoms like POTS. So POTS is a gravity-dependent condition. Anyways, what they do is they have a stocking which is kind of goes on your legs, and it has got Velcros, and it's got some chains in the ankles for donning and doffing. And then the second part consists of like a cycle shorts, bicycle shorts, and people are able to tolerate that better. They cost a little bit extra, but that is what has people are more kind of compatible with, and there's more compliance in using those kind of braces. Sleep is an important part, so you should be using different kind of adaptive pillows for sleep and function. Household adaptations, we often don't talk about them, and these are small little changes, but they make an incredible difference to the quality of life for the people. There's a bunch of different things that they look like, but the tremendous amount of impact they have quality on life is important. And they could go anywhere from like grab bars or like railings, and then you get more specific. If you have problems with smaller muscles, you can use some doorknob openers. You could get into daily activities like a grabber or a reacher. You could use a jar opener. There's for showering, you could use a shower chair. You could also use a shower hose. You could work ergonomic modifications with laptop stands, and if you're in a work environment, if you can't read and write, you could use these grippers. There's a bunch of like soft foam kind of like cones which are available, which you could put on anything so that you're not really grasping it too tight. You have a bigger, broader grip, so you're not using your pincer grasp because you don't have that. Moving on to some of the nitty-gritties of pharmacological management. I don't know if you remember, we talked about there were nociceptive pain initially, which was more in the joints and muscles, and then they went on to become more prevalent neuropathic or nerve-related pains. Now, the third kind of pains that people have are consequences of autonomic dysautonomia, whether they have gastrointestinal pains, pelvic pains, and bladder pains, so on. So for nociceptive pains, they're related to the injury or tissue damage happens in early stage of life. There's damage of large and small joints, and the usual medications pharmacologically, you can use any over-the-counter analgesic, Tylenols, Advil, Aleve. If it is a severe injury, you could also get a short course of opioids as well. However, things get interesting when it becomes more of like neuropathic. When it becomes neuropathic and there's hypersensitivity of the somatosensory nervous system, which then kind of leads to changes in pain signaling and neuronal pathways, then you delve into a group of medications. There's gabapentinoids or anticonvulsants, which are your gabapentin and pregabalin. Then there's duloxetine, SNRIs, which are your other selective serotonin and noradrenaline reuptake inhibitors, and tricyclic antidepressants. And I'm going to talk a little bit about them in the next slide. Now, different providers provide different kind of medications for neuropathic pains, but what is important to know is that all these neuropathic pain medications have certain side effects which can play a role in your orthostatic intolerance and your fatigue and your sleep. And that is why it's important to identify which medication might be suited to one Ehlers-Danlos patient versus may not be suitable for others. Specifically, if we look at here, like tricyclic antidepressants, the amitriptylines, the nortriptylines, the Elavils, they cause fatigue, but they also cause a lot of orthostatic intolerance. So people who have orthostatic intolerance, moderate to severe, they should not be using tricyclic antidepressants because they would be at a higher risk of worsening of their orthostatic intolerance and fatigue. The same thing. The second most common is gabapentin and pregabalin. It leads to fatigue and weight gain, so people should be mindful of. And then the duloxetines and the venlafaxines, they can cause some headaches and nausea and palpitations, which are predominant side effects which come with these medications. Most of these medications help with sleep disturbance. So if you have a sleep disturbance, then you could use one of these, provided they don't, their side effects don't collide with some of your symptoms. And SNRIs are also good medications for depression. So if you're feeling low, if a patient is feeling low, they could use, duloxetine would be a more preferred medication as compared to gabapentin or amitriptyline. This is another medication for pain management, which has recently gotten a lot of kind of attention. It's called low-dose naltrexone. Now, naltrexone is an opioid antagonist, and medical healthcare providers mostly know of it as something which we use. If you have an opioid overdose, then this is an antidote. But in the last 10, 15 years, there's research which have shown that it has other mechanisms of action as well. So it works and it kind of regulates this opioid growth factor. So it blocks that opioid growth factor receptor. The effect lasts for around 6 to 8 hours, and that results in a biofeedback loop of production of endogenous opioids. So it has an analgesic action. It also has an immunomodulatory effect because what it does is that it regulates the TLR4 or the toll-like receptor 4, which is found in macrophages and microglia. So people who have mast cell-related chronic pains, it kind of modulates that and reduces that kind of pain in patients. Commonly, it's used as a dose of the dose has to be titrated, and I'll show you a study about that. And the usual dose is between 1 to 6 milligrams. You can up titrate it on a weekly basis, starting at 1 milligrams and then go up as high as 6 milligrams. Okay, I've only got 1 minute. All righty, side effects are pretty low. There's often people complain of vivid dreams, and some would have tachycardia, but otherwise it does not affect your liver function, although it's excreted by the liver. And I'm going to probably skip this study. This was a study done by a colleague of mine, Dr. Norman Marcus. He actually did a retrospective chart review of naltrexone in EDS patients, which was kind of like proven that it really works in patients who have Ehlers-Danlos syndrome. Non-pharmacological approaches for POTS, like orthostatic intolerance. I would not call it just POTS, but orthostatic intolerance is such a common comorbid symptom, which then causes fatigue and all the cognitive features. And okay, that was a small minute. All righty, so we've talked about the exercises. You can increase your water intake around 4 to 5 liters of water a day, 5 to 10 grams of salt intake a day. We spoke about the exercises, the compression garments, sleep hygiene. I'm going to come into a different slide. And these are just a bunch of medications which are used to control POTS or mitigate the symptoms of POTS. One thing I would say, a lot of the biggest evidence is about propranolol. But propranolol, it reduces the heart rate, but it causes severe fatigue. So if you're taking propranolol for tachycardia and palpitations, and if you're feeling more fatigued, then you need to probably move on from propranolol to ivabatrine or another medications. I'm going to probably skip this slide. One of the, maybe just one point here is that midodrine is a medication which kind of increases the venous uptake, and people who generally have low blood pressure and have tachycardia, this is a better medication for them. Okay, where am I going from here? Yeah, sleep and fatigue, again, as I mentioned, fatigue is very prevalent. There's multifactorial reasons for both sleep and fatigue disorders. Common reasons are inadequate hydration, heat intolerance, low blood volume, decreased cerebral blood flow. Sleep disruption is very common. It is there's not a bunch of research, but there's some research which shows there's increased prevalence of obstructive sleep apnea, insomnia, and periodic limb movement disorders in EDS. And oftentimes, people have this hyperadrenergic state because of chronic anxiety or because of autonomic dysfunction, that they talk about feeling wired, that they're just not able to sleep and shut down their system, which happens. And one thing you should do is find out common reversible causes for fatigue, iron deficiency, hypothyroidism, vitamin D deficiency, and if you should get a blood work, and if you have those, then you should get treated for them. this is a fatigue slide, but I think most of the stuff is same, fluid intake, water. One important thing is you should avoid any triggers, and also look for some educational support, discuss with your health authorities or, the school folks, and also at employment for modified duties and disability services. I didn't dabble into some of the adaptive stuff today for time. The last thing I want to talk about, very important, you have to advocate for yourself. Okay, and a part of the whole management is about. I think I'm moving too fast. So advocating for yourself, and you should advocate in a way that your message is heard, and you meet your needs. The best way to start that is stay confident. Your experiences are valuable, and they're valid too. When you go for a medical appointment, have a goal, discuss one or two most prevalent things. Focus should be on sharing the information, discussing the priorities and treatment strategies. And you should also have realistic expectations one should have about medicine. Medicine does not know everything about everything. There's limitations to modern medicine. There may not be a cure, but the providers can always help you work around finding treatments and working strategies along with you. The last thing I would say is, these are unique individuals. Their experiences are unique, and they should do as they feel is best for them. What I have learned in my last 80 years, and I've seen a variety of individuals when they were not at a great point in their life, and at other times when they were really doing well. To me, it seems like it is about resilience. Folks who are resilient, who figure out their own hacks, and understand and know for a fact that there would be ups and downs, but they have their hacks for good days and bad days. Those are the ones who do really extremely well in terms of having a good quality of life throughout their life. And so you should stay resilient. And whenever you need some help from medical system cannot fix you. It can just help you guide and provide some strategies. But it's your journey, and everybody has to go through their own journey. I think that's my last line. Sorry for going over time.
Amazing. Thank you so much. So we have about 8 minutes for questions and answers. We'll take any questions from the audience as well as from the Zoom chat. We have 2 mic runners, Sid and Monica. They're both undergraduate kinesiology students. So if you're in the room, just raise your hand and they will come to you. It's really important that we use the mic so everyone in the room can hear what's being asked as well as everyone online.
Hi, I really enjoyed your presentation.
Thank you.
I had a question. So you talk about advocacy, specifically self-advocacy, sorry, which is really important, but sometimes is really difficult to do in the face of medical gaslighting. I find that's really bad. How do you go about balancing that in that challenging situation?
Great question. There's a few different strategies you could use. First thing is, take a patient or take a family member or an advocate with yourself who can also kind of advocate on your behalf. Be courteous, and if you can only try and educate anybody as much as they like to be educated. So don't take big binders or articles for them to learn, because nobody's going to do that. But try and show them some snippets of the evidence that exist about what goes on. And hopefully they listen to you. Otherwise, I would find a different provider. Yeah.
Hi, thanks
Hi.
so much. I just had a question as to whether you had come across any, either in your practice or research, the use of hydroxychloroquine as a way of managing some of the symptoms of pain and fatigue.
Yeah. Yeah. So hydroxychloroquine is used as a drug for inflammatory disorders. Now, EDS also comprises of a group of heterogeneous conditions until the specific diagnosis is made. So a bunch of people who would have chronic widespread joint pains without any known cause may be given a diagnosis of Ehlers-Danlos syndrome, and then whereas they may have an inflammatory disorder, in those individuals, it's more likely that hydroxychloroquine would work. Having said that, there's some other research which is coming out, which is also suggesting that hypermobility spectrum disorders might be an inflammatory condition, immunological inflammatory condition. So I would not be surprised that in those patients, hydroxychloroquine works. The challenge with hydroxychloroquine is the significant risk of side effects that it comes with. But till the time people are aware of that, the liver function and the eyes that it affects, and you get the tests, then it should be fine. We don't prescribe it commonly in our practice.
Thank you. Hello. Thank you for your presentation. I had a question about the like brain fog and cognitive symptoms. When you were presenting, you talked about those symptoms in the context of like the cardiac pathways, and I was just wondering from like either from like a scientific perspective, what has been researched and known, maybe from like fMRI studies or like actual like like scientific evidence that the cardiac symptoms and blood pressure issues cause the, I don't know, reduced perfusion or something. Is there evidence like that? Or is it like in your world as like a expert in this field, is that like what we believe based on a confluence of evidence, but maybe not like directed studies? Because I always assumed it was from like a combination of things like sleep and pain and mood issues like all together. So yeah, if you could please comment on the etiology of the cognitive symptoms, please.
Sure. Short answer, yes, it is a confluence of multiple different things. Is that it's sleep, it's fatigue, but the fatigue is probably coming from the autonomic dysfunction. Now, there's no direct evidence in Ehlers-Danlos syndrome to explain that, but there's evidence in other conditions which have shown that this happens. Most of the, there's two different kind of evidence which exists. One is in chronic fatigue syndrome. In chronic fatigue syndrome, they have done this study. It again comes out of Denmark. Bo Bertelson's lab has looked at fMRI studies of cerebral perfusion and then commented on how gravitational forces and orthostatic measures of cardiac function affect the cerebral perfusion. So that is one literature where it comes from, which has POTS with chronic fatigue syndrome. The other literature which comes from is, again, from NASA-based studies, where they've looked at their astronauts and they've found similar findings. But there's no direct evidence as yet in EDS, but we believe that it's a similar pathophysiological mechanism which is a part cause of the cerebral symptoms that a patient experiences.
Can we just take two questions from the online audience before we continue with the in-person?
Hi, I was just wondering if you could comment on the sort of manifestations that happen with the head and neck, particularly when you think about, you were talking about sleep apnea, and a lot of us tend to be thin because for multiple reasons, but we're not going to be screened for sleep apnea necessarily. Allergies, sort of the mast cell activation, whether you call it gaslighting or something else, we have to decide which referrals are most important to us a lot of the times because we're managing our own care. So I've been really curious about that aspect of.
That's a fair point, and unfortunately, that's one of the limitations of medical health science and the social system that we live in. I kind of mentioned it in my advocacy slide. You have to definitely focus on some things which are more important as compared to the others. But then what you could do is use some of the empirical strategies. While you're trying to figure out the more important stuff, there are still empirical strategies that you could use for some of the other symptoms that you have, which have not yet been investigated or explored, if it is truly because of, let's say, mast cells or not. Like in our practice, we get a bunch of patients who have symptoms of, rash, hives, itching, and so on. We run a baseline tryptase level for them, and then we hand out a tryptase test that they have to do within 24 hours of actually getting a flare-up. And we've not looked at the data, but my belief, looking at all the reports that I see, is hardly 5% of them actually get an actual increase of tryptase levels during a flare-up of events. So it may not be mast cell, but it might be something else. So point being is, like, if you can try and empirically manage those strategies while you're trying to explore and figure out whether it's truly mast cell or if it's truly sleep apnea or not, that would be a way could be one of the strategies.
Perfect. We only have a couple minutes, less than a minute left, so we'll take 2 questions from the online audience, and then people can speak to Dr. Mittal during the breaks if that's okay.
Okay, so there's a couple related to exercise, and I might try and smash them together so that we can you can maybe address both at the same time. One is about kind of your recommendations about age and heart rate. If there's some kind of level people should be aiming for with their daily exercise, and then the other is also related to exercise recommendations for those. Well, they ask, are the recommendations directed only to those not experiencing fatigue, as the person points out that those recommendations don't account for post-exertional malaise or the finding that sometimes exercise can exacerbate your fatigue. And so what do you do in those situations?
Yeah, fair questions. So the first question I'll answer is the post-exertional malaise. What we tell patients, a usual thumb rule for that, and it's different for everybody, is there would be some fatigue. Like even if a normal person exercises, after exercise, they would have post-exercise fatigue and their muscles would be sore. If you have that same symptom which continues for 24 hours or more, then you overdid that exercise and you need to reduce the intensity of it. Try to keep the duration as you can, and then try to reduce only the intensity of that workout. So that helps gradually figuring out when you would have some fatigue, but not a real post-exertional malaise that sets you off for 2, 3, 5, 7 days. About the heart rate, there's some literature in cardiac science on EDS labs from Fu, which talks about using 220 minus your age as the baseline. And then what you can do is you could go up to 80% of that heart rate. Now, it is different for people if they have comorbid heart condition, like if you have CHF or if you have ventricular arrhythmia or any other heart condition, then that principle is not valid. But if you're otherwise healthy, then it's 220 minus age times 50 to 85% of the cardiac heart rate that you could go up to. I hope that answers.
Great, thank you so much.
Not a problem.
I forgot to mention at the beginning, we have an exciting panel. This was suggested by some knowledge users that have informed our event. We'll be having Dr. Mittal, Dr. Tinkle, and a patient and a physiotherapist. And we solicited a lot of questions from you guys in advance, but if you have any questions you want me to add and ask that panel, just come talk to me. If you didn't get a chance to ask your question now, as I mentioned, all of our speakers are really here for you, so feel free to talk to them during